So multidisciplinary team meetings incorporate three components. Very simply put, one part is it's focused on disease sites, usually. It's a clinical discussion, at least from an oncology setting. Yeah? That's what MDT means. It includes multidisciplinary groups of experts. So it can be surgeon, can be medical oncologist, radiation, pathology, nursing. Let's not forget our colleagues in allied health as well. Speech therapists, occupational therapists, physiotherapists, pathologists, right? So all these groups of experts come together, usually focused on a particular tumor type. Sometimes it cuts across because now we have what we call molecular tumor boards, where we do all these tests across many different tumor types with the focus of using evidence-based consensus, right, for the best care for our patient, right? So the key words here are, again, collaboration, getting groups of experts together and coming out with the best treatment for our patient, right? So at the end, at the center of this all is patients. Now, historically, MDTs usually involve, like I mentioned, a group coming together, usually about once a week or once in 2 weeks. And this has been going on for many decades in many places, right? Now, the discussions end up with a certain management plan, which will be carried forward by the treating physician. And traditionally, it was paper discussions. Patients are not in the room, right? We discuss their case. All the information is confidential. And then we hand it over, usually paper written. Sometimes now it's electronic medical records. And the primary doctor will review that and say, okay, MDT has discussed this, I will follow through, right? Because there are legal repercussions as well, right? In Singapore, there were many cases in the last decade where at the end of the day, it came back to the MDT. What did the MDT decide? And unfortunately, this also means the MDT has to take that responsibility, because there was cases where the patient had sued the MDT for the recommendation. So that's why it is very, very important how you conduct it, how you document it, because there are legal repercussions as well. Now, why MDT? MDT has been proven to improve survival, right? Many of us think it's only the drugs, but it's not just the drugs. It's about the combination of expert advice that leads on to what drug should be given or what treatment should be given, maybe radiation, maybe surgery, right? So it improves survival. It reduces variation in care. The references I've written down there, so I'm happy to share these slides. You can look at some of these references, but basically, if you just do it yourself, right? Another doctor may think about it differently based on their experience. Another doctor will think about it even differently. So everybody will have their views. But here you come together and you come with a consensus agreement, right? So the variation is a lot less and everybody is streamlined to follow particular guidelines. Maybe NCCN, which many of us use, maybe ESMO or ESCO, right? And shortens the time to treatment. Why? How does that happen? So during the MDT, the treating doctor usually is there, and other doctors they want to refer to are there as well. So when you discuss the case, if they say this is very critical, we need to address it urgently, the radiation doctor will say, yes, I can force into my clinic tomorrow. I will try to do the radiation fast. So it's short.